I only have 2 minutes and 50 seconds, however, to speak, so I will have to speak even more quickly than I normally do. Once again, thank you very much for having me here today, and it is a double honor for me to be able to speak on this very interesting topic that many of us in Israel and the United States have both worked on and hope to have some treatments for our patients in the near future. These are the disclosures that I mentioned before, to which I add the fact that I was the principal investigator at the University of Pennsylvania for several of the clinical trials I'm going to talk about today. I have no financial interest in any of the companies or the clinical trials in which we conducted them. So for a minute, I realize I'm what we call in English preaching to the converted here. We all take care of emphysema patients, and I think that one of my pet peeves when I talk to my trainees and they talk about patients with COPD exacerbations is to put patients like this into the same category of someone with chronic bronchitis and expect that the treatments that we administer are going to work equally well for patients with severe emphysema and those with chronic bronchitis. We have algorithms in our hospital for COPD exacerbation, but it seems to me if this is what the lung looks like, that any pharmacologic intervention that we have for our patient is going to be of marginal benefit. And so, based upon some of that information, that pharmacology was not very beneficial for patients with severe emphysema, there was an operation that was developed actually 50 years ago, but rediscovered by my colleague from the University of Pennsylvania, Dr. Joel Cooper, who is our emeritus professor of thoracic surgery at my hospital. And he rediscovered data from Otto Brantigan from the University of Maryland, who first performed an operation to remove portions of emphysematous lung and then to staple off the edge of the lung to try to decrease the amount of hyperinflation and to improve elastic recoil of the lung. And we all know the results of the NET study. They remain controversial, I think, years down the road after we've still seen the data multiple times. But the bottom line is this study as designed, which randomized patients to best medical care versus best medical care plus lung volume reduction surgery, was not a positive study. Subgroup analysis showed that it was a positive study, but as it initially designed, it was not positive. In addition, there was evidence of increased mortality and negligible functional gain. There remains significant controversy over this as to whether there are and whether there are not indications for doing lung volume reduction surgery. But what grew in the shadow of this data were other attempts to try to accomplish the same goal with less morbidity and lower mortality. And these were bronchoscopic approaches to try to decrease lung volume in patients with emphysema, or to try to find other ways to palliate emphysema in patients who would not potentially be candidates for lung volume reduction surgery or lung transplantation. And these included plugs or stents just to occlude airways leading to areas of emphysematous lung, one-way valves for diversion of gas away from emphysematous lung zones, biologic and thermal remodification, airway bypass stents to the lung parenchyma, bronchial springs or coils to try to improve the elastic recoil of the lung, and really what you could do or attempt through a bronchoscope was only the limit of one's imagination in terms of how you could approach that patient with emphysema that I showed you the picture of from the Netter drawing. One of the first approaches that was studied in human clinical trials was the idea of putting a one-way valve into the airway. Very simplistically, what this hoped to do is that bronchoscopically, if you could place a valve into an airway, ideally, if the valve allowed air to exit from the airway and not enter, then you could then induce atelectasis, at least focal segmental atelectasis, decrease lung volume, and, as originally hypothesized, achieve the goals of lung volume reduction surgery without the surgery. So the idea, again, was to decrease target lung volume, shift ventilation to more well-preserved lung zones that may be more well-perfused at the bases, and to potentially reduce dynamic hyperinflation. This is another valve that was used for clinical trials both in the US and elsewhere. This is the so-called IBV valve, the umbrella valve. And here you can see the valve compressed in a catheter and some of the valves in place in situ in the right or below. These were very easily inserted through bronchoscopic means. Here you see the delivery of the IBV valve through the working channel of a flexible bronchoscope. Could be done under conscious sedation or deep sedation. You place the valve is expanded in situ, and as inspiration occurs, air is blocked from entry, but as exhalation occurs, air, mucus, and theoretically bacteria is allowed to leave. This valve was studied in a pivotal trial, which is yet to be presented, but will be presented at ATS. But the valve that I showed you initially, the Zephyr valve, which was a trial run by the Emphasis Corporation, which no longer exists, ran a pivotal trial which was published in the New England Journal of Medicine in 2010. And this was a randomized controlled trial, randomized 2-to-1 to patients getting the valve plus optical medical management versus optical medical management alone. These patients all received pulmonary rehabilitation as part of their medical management, and they were evaluated bronchoscopically and with imaging. And the results of the study were positive, meaning that they met their goals and endpoints of the clinical trial. Their goals being a significant improvement in FEV1, so they saw an improvement of 4.3% in the treatment group versus a decrease in FEV1 of 0.25 in the control group, with a p-value of 0.005. They also saw significant improvements in 6-minute walk and SGRQ. The problem with this study, in part, was that although they hit their primary endpoints, that these improvements were not felt to be very clinically significant. So we would rarely administer a medication that only gave our patient a 4.3% improvement in their FEV1. And an SGRQ improvement of -2.8 is below the generally accepted threshold of -4 for a significant intervention, clinically significant intervention. The other problem with this study was complications, or were complications. So patients developed COPD flares at much higher rates than controls, hemoptysis at higher rates than controls, and pneumothorax, although that was not statistically significant. And because of these problems, the summary of this study was that it provided only modest, at best, increases in FEV1 at 6-minute walk. That if they did subgroup analysis, and this again gets back to the problems that happen with a NET study in terms of doing subgroup ad hoc or post hoc analysis, that there was significant improvement in patients who had higher radiographic heterogeneity of their emphysema, and in patients who had radiographic evidence of complete fissures. But again, this was not an a priori endpoint for the clinical trial. And these modest improvements that were seen overall came at a cost of more frequent adverse events, as we talked about. So what do we take away from this clinical trial, which was a major paper in our field, interventional pulmonology, randomized trial, New England Journal of Medicine? Well, we take from it that it may be beneficial, bronchoscopic lung volume reduction using the endobronchial valve in a very selected patient population, but that we need to reevaluate this population in a prospective fashion to know this better. And this population would be heterogeneous emphysema with absence of collateral ventilation, interlobar collateral ventilation. When the FDA panel in the United States 4 years ago, looked at the results to decide whether or not, based upon this quote-unquote positive study, whether they should approve the valve for use in the United States, they voted 11-2 against approval. And what's interesting about the FDA meetings is that you can actually go online and read the actual discussions. They're all transcribed. So these are actual comments that were made by participants on the FDA panel. Insufficient evidence of benefits to outweigh the risks. Once you approve it, the cat is out of the bag. It kind of breaks my heart to vote against this. So there were some people who really felt strongly that we need devices to use for patients with emphysema, but perhaps this was not the right device, or perhaps not the right device at the right time. So another approach almost simultaneously was being studied in pivotal trial, and this was also helped to be developed by one of my mentors at the University of Pennsylvania, Joel Cooper, who also did the first modern lung volume reduction surgery. This was the so-called airway bypass procedure, in which there was a creation of an extra anatomic passage between the collaterally ventilated pulmonary parenchyma in patients with severe emphysema and the larger airways, which allowed gas which was trapped within the lung to exit when it otherwise could not. And this decrease in the volume of the trapped gas would, in theory, lead to improvements in inspiratory muscle strength, reduced dyspnea, and improved quality of life. And the idea was that this would be a bronchoscopic treatment which would be minimally invasive and done potentially on an outpatient basis. It, however, for any of you who have participated in this procedure, was somewhat technically challenging and complicated. required using a Doppler device to first identify where the blood vessels were and were not, so you were not puncturing a pulmonary vessel. Unlike standard TBNA, where it would be no problem to puncture a vessel because you're going through an elastic wall of the vessel and then removing your needle, in this case, what you're doing is puncturing through with a needle and a balloon and then placing a stent. And if you place a stent into a vessel, it was a significant problem. So you needed to know where the vessels were and where they were not. The next problem was the fact that you could place the stent successfully in avascular regions, but that the stents themselves would become occluded by granulation tissue, and this would happen very rapidly. So what the investigators learned was that they actually had to use drug-eluting stents. So taking a tip from the cardiologist, they eluted paclitaxel and showed that they could maintain reasonably long-term patency of these stents put through the airway wall into the lung parenchyma, but they required this drug elution, and this was very important. So on the basis of pilot studies outside the U.S., a randomized clinical trial, sham-controlled, of this was taking place in the U.S. and elsewhere, and recently published in Lancet in 2011 by my friend Pallav Shah from the Royal Brompton Hospital. And unfortunately, this was a negative study. So if you look at the results, looking at baseline compared with day 1, month 1, 3, 6, and 12, look at FVC, MMRC, SGRQ, change in RV, no significant difference between sham and control. So extremely well done clinical trial, but negative results. So why were the results negative? The pilot data, and I don't have time to go into it, was very promising, especially in patients with very high residual volumes, and in patients in whom you could successfully place multiple of these stents into the lung parenchyma. So the hint is from the breakdown of the data. So if you look on top, these are the changes of residual volume from baseline on day 1, airway bypass in blue, sham control in the reddish brown. And what you see is that there was a significant decrease in residual volume on day 1 in those patients who had airway bypass. But in those same patients by month 6, those differences were gone. And why were they gone? If you look at why they were gone because on day 1, all those stents were open, and even with paclitaxel elution, by month 6, the stents were occluded. And the airways that had clear lumens, the residual volume in that specific lobe as measured by CT could be shown to be decreased still, but in those airways that the stents had become occluded, the volumes were no different from sham control. And so keeping these stents open long-term proved to be much more problematic in practice than it was in theory. And so unfortunately that trial is stopped and not planned, as far as I know, to be restarted. But others are looking at other ways to try to palliate patients with emphysema, especially those that have significant collateral ventilation or have homogeneous emphysema or both. And this is a device that you may have seen and may have used in clinical practice. This is a coil, lung volume reduction coil, with a nitinol coil which can be implanted as a straight device into the patient and then coils automatically due to its natural properties once it's inside the patient. It has a ball in the proximal end that allows for removal, certainly early on after placement, if you're not happy with the placement or if the patient is having a problem. And the goal, ideally, is to increase elastic recoil and to decrease lung volume, potentially to reprofile the diaphragm and to apply tension to adjacent tissue to expand the airways and allow for improved air exit during exhalation. So the technique involves placement, as I said, of this straightened coil through a catheter, through a flexible bronchoscope into the target airway. To deploy the coil, watch the lung itself remodel around this coiled nitinol device, and then to release it with a forceps. The ball will then be visible, and you can recapture with the forceps and remove, certainly early on. This is from a paper from Chest from 2011 showing multiple coils in the upper lung fields of a patient with severe homogeneous emphysema. Here you see about 10 to 14 coils altogether in this patient. Really remarkable what you can do with these coils. And the data, which was again EPUB'd in Chest 2011, is really remarkable. Again, this is non-controlled data, so this is a multi-center pilot study, but with no control. And what you see, just looking at the last column with a 6-month overall post-treatment, is a improvement in FEV1 of about 15%, a decrease in RV of about 11%, significant improvement in 6-minute walk distance of about 84 meters, which to me is a very significant improvement, much more so than was shown, for example, in the vent study with the Emphysematous valve. And the change in SGRQ really is almost unbelievable, which is a change of almost 15, minus 15 in SGRQ, understanding that the change in net with LVRS was minus 8. So this is an almost double the improvement in SGRQ compared to net. Again, non-controlled data. And what's interesting to me also is that this is durable data, again, in a non-controlled pilot study, but you can see that at baseline, looking at changes in 6-minute walk distance, that this is maintained over 6 months. That normally what we would see is an initial improvement with whatever intervention you're doing, and then a decline over time. And so far, at least this preliminary data of a short-term follow-up, we're seeing no decline over time. What are the other approaches that are out there? Another approach that's meant to address the limitations of endobronchial volume reduction due to the presence of collateral and lobar ventilation is so-called biologic lung volume reduction. And this concept was actually developed by someone who's here today, who's one of the most brilliant people, I think, in pulmonary medicine, Ed Ingenito. And Ed came up with the idea of modifying some of the techniques or manifestations that we see in pulmonary medicine on a routine basis. So all of us have seen so-called medical lung volume reduction, where we have a patient with upper lobe predominant emphysema, they get a bad pneumonia, after the pneumonia heals, they get scarring, and their breathing improves, their FEV1 improves, their exercise tolerance improves. The Japanese took this a step further and actually used a blood patch for significant emphysema. So it's the cheapest kind of bronchoscopic lung volume reduction, which you take autologous blood, put it through a catheter into an area of significant emphysema, and look for the retraction of the lung parenchyma and improvement in lung physiology over time. Well, the idea of biologic lung volume reduction is just that, except using specific chemical interactions to try to remodel the lung parenchyma. The initial concept that Ed Ingenito came up with was a fibrinogen-thrombin combination, which put in through a relatively complicated dual catheter system would get into the lung parenchyma, polymerize, and then cause focused scarring within the lung parenchyma to induce targeted lung volume reduction. And so this was studied in both pilot studies as well as in a phase 2 trial. The phase 2 trial was published in the Blue Journal in 2009 by Jerry Kreiner and colleagues. And what you see is both a low-dose group, which was 10 cc's per site, and a high-dose group, which was 20 cc's per site. And they showed that it was safe and reasonable, and they saw improvements in physiology and functional outcomes with this. This has then been modified to a different type of material that's now injected into the airways in patients with advanced emphysema. And this actually is being studied currently in Israel. I understand. I do not have experience with this technology in the United States, but I believe it will soon be coming to the United States for clinical trial. And this is the delivery of what's called an Emphysematous polymer lung sealant, or AirSeal, which is delivered through a catheter as a foam, which works its way into the peripheral alveoli. The small channels and small airways and collateral channels are obstructed. The gas in the sealed area is absorbed, leading to volume reduction in the targeted lung zones. And this is designed to be effective for both heterogeneous emphysema and homogeneous emphysema, because you're not only occluding the airway, but the collateral channels between the lobes. So that if you occlude the collateral channel, you may solve the problem of collateral ventilation. So these are some images from patients from Germany who underwent insertion of this foam sealant. And you see the pre-images on the top and the post on the bottom here, with 2 sites injected into the right upper lobe. Again, 2 sites, and here 3 sites. You see a significant change in the appearance of the right upper lobe with volume reduction in the side. The 6-month results were recently published in Respiration, and what you see are significant improvements in RV over TLC, FEV1, FEC. 6-minute walk was not clinically significant. SGRQ was. And again, you see a significant improvement in SGRQ above the threshold of -4. You see improvements in FEV1 of 10%, which are, I think, relatively meaningful. And 6-minute walk test, not as good as we saw with the Coils, but still 25 meters is a reasonable improvement and one that we might consider in our patients. So there is a favorable safety profile to doing this emphysematous lung sealant. Patients do get almost uniformly a flu-like reaction with fever for about the first 24 to 48 hours, chest pain, leukocytosis, and you can blunt this flu-like reaction by giving prophylactic steroids. Patients do have some degree of significant COPD exacerbations. About 9% required hospitalizations in the first 140 days. Again, almost any intervention that you do bronchoscopically in patients with COPD, emphysema specifically, will lead to acute exacerbations of COPD in a small percentage. So this is not a surprising amount that we're seeing. And then pneumonia, about 4% of patients within the first 140 days. But I would posit to you that it's very difficult to discern what is pneumonia and what is not pneumonia. These patients who are developing an infiltrate in the area that you're putting sealant, and they may have an inflammatory cytokine-mediated reaction causing fever. Is this pneumonia, or is this local reaction, local inflammatory reaction? I think it's very difficult. No bacteriology from any of these patients was obtained, so we don't truly know whether this is an infectious or a non-infectious complication. Lastly, again, this is a technology that I don't personally have experience with, but there are a number of publications out regarding this exciting technology, which is bronchoscopic thermal vapor ablation. So perhaps the simplest and cheapest, after using your own blood to try to cause volume reduction, would be to shoot a flow of steam up into the airway of the lung in the heterogeneous upper lobe predominant patients, and to try to remodel the lung by using steam. And so this is a device that generates steam of a particular temperature using sterile water. You fit to a standard bronchoscope, and you would use one catheter for a procedure in each patient. And you can vary the time and the flow rate as well as the temperature of the vapor that you're going to administer. So there is a study of a single lobar treatment in patients with upper lobe predominant emphysema that was conducted as a multicenter trial. Initial feasibility studies were published in the Annals of Thoracic Surgery in 2009, and this more recent study was published in the, or is EPUB'd in the ERJ from 2011. And what they showed was using 10 calories per gram in single treatments in the upper lobe, they can achieve volume reduction in patients that was similar to what's seen in some of the other bronchoscopic treatments. About, all 100% of patients had at least 10% lobar volume reduction, and many significantly more. And the thought was, and I'll show you the data, that collateral ventilation was not a significant impediment to success. And this is the data that was published in the ERJ paper by Snell et al. And looking at 3 and 6 month outcomes with this lobar reduction using steam. What they saw was a significant decrease in RV of about half a liter, 400 to 500 cc's. Significant improvements in FEV1, FEV1% improvements at 6 months of 17% improvement. SGRQ, again, markedly improved, -14, similar to the Coils, much better than the valves, again, in a non-controlled study. Again, when we do sham-controlled studies, we see that these numbers often go significantly down, but still very impressive for pilot data. And 6-minute walk test, 47 meters and at 6 months. And what's interesting is, just going back, that you can walk further at 6 months than you can at 3, which is impressive. This is a study that was just EPUB'd in respiration by also the German group, where they looked at retrospectively the presence or absence of collateral ventilation to see whether or not it correlated with the outcomes of bronchoscopic vapor thermal ablation. And there was no correlation whatsoever with any outcome with the presence of collateral ventilation. So again, this treatment, like some of the others that we talked about, including the sealant, may obviate the need to decide whether patients do or do not have collateral ventilation, which for the valves, for example, is extremely important to determine whether or not you're going to have success. So in terms of the status in the United States of clinical trials, the Emphysematous valve, after the negative or the positive study, which was then not approved by the FDA for clinical use, you can use the valve in Europe, but not in the United States. In the United States, it was purchased by a company called Pulmonx, which is marketing it outside the U.S., but there's no plans, as far as I know, for restudying the valve in the United States. The IBV valve, we're waiting the results of the initial pivotal trial, which was a randomized sham-controlled trial of bilateral treatment using the IBV valve. This will be presented at ATS in 2 months. And I'll encourage you, if you're not going to ATS, to think about going to San Francisco to hear the results. There will also be a new pivotal trial based upon a new treatment algorithm that will be starting in the latter part of this year. Airway bypass, unfortunately, is deceased. I think this was a great idea, waiting for someone to rejuvenate it and try to keep those stents open long term, because the pilot data still was very impressive. In the United States, there are several other pivotal trials with Aristeel, the lung valve reduction coils, and thermal ablation, which are scheduled to start in 2012 at multiple centers in the U.S. And so that data will be forthcoming in the next couple of years. So just to finish in the last few seconds, what are the considerations that we need to think about in whether or not our patients will be candidates for these clinical trials? Because in the U.S., we have no device that we can use off the shelf that's approved for patients with emphysema. Well, we need to consider the degree of hyperinflation. And for the most part, the greater the degree of hyperinflation, the more likely a patient is to benefit from your intervention. In the patients who have heterogeneous emphysema, they tend to benefit more than patients with homogeneous emphysema, but more and more treatments which don't require the presence of, or work in the presence of collateral ventilation will work in homogeneous emphysema as well. Some of the studies require looking at completeness of fissures because this will give you a clue as to the presence or absence of collateral ventilation. And the valve studies going forward in the future will likely need to look at completeness of fissures. Reversibility is very important, and this is the major distinction between, for example, the valves and the coils versus some of the other interventions we've talked about. The FDA in the United States is very concerned about this and likes the concept of doing an intervention for COPD, for emphysema, that you can then reverse and get the patient back to baseline, get them to transplant or LVRS if they need to. But some of the best treatments that we're coming up with may well be irreversible in terms of the effects upon lung parenchyma, so we have to decide whether the risk-benefit ratio favors that. And lastly, the duration of effect. So is this going to be a transitory benefit for a few months, or is the benefit going to be for a few years?